third edition of Sundaram Fastner's lecture series on open dialogue as a response to crisis and suicidal distress, working with vulnerable and marginalized people by Professor David Mosse. Thank you, Professor Samuel, and also MSSW for hosting us in this beautiful auditorium. I request Professor Raja Samuel to welcome the gathering.
A very good morning to all of you. It's indeed a delight to welcome all of you for this a special lecture. And I'm honored to welcome Professor David Mosse for consenting to come to Madras School of Social Work and deliver this lecture. And I'm honored to welcome, of course, our own Professor Vandana. It's a delight to work with the Banyan team, entire Banyan team and the BAM team for the academic richness that they bring in this collaboration. The variety of intense discussions that take place in this campus because of your involvement. So we cherish that. We are privileged for that. And I welcome everyone that has come from the academy as well as BAM. Welcome Dr. Anbudurai, who's here. And all the leaders. Yeah. Of course, the director of Banyan, Dr. Kishore, a warm welcome to you. And all those who are interested in this topic in particular, this is a very important topic. All of us are engaged in this in some way. The government also is very keen on seeing some solution for this. And there are a whole lot of people who are interested in seeing how we can prevent suicides and what can we do to help people who are inclined with or having mental health issues that lead them towards suicide. So I just want to welcome all of you, and I'm sure this session will help us understand these things better, and I'm sure we will be motivated to work further. Very, very warm welcome, and welcome all of you to sit back and take in as much as we can and support these endeavors. And I also appreciate Sundaram Fastners Limited for supporting this series of lectures. It's a very important support that they are providing. Thank you.
So welcome Professor David.
Thank you very much for this warm welcome, and thank you, Dr. Professor, for your hosting of this event. I'm delighted to be able to deliver this lecture in the Sundaram Fastner series with BAM and the Banyan. I'm immensely grateful for the privilege of spending time with the Banyan and the BAM team over the last few days and weeks, or a couple of weeks, and visiting the emergency care and recovery centres, the homeless shelters, the Home Again homes. And these visits and discussions have been inspiring and underlined for me the real value of mutual learning from working with marginalized people in distress across different countries and contexts. Now, I'm going to be talking about the UK and my work there, but I'm very much aware of the need to place this in different cultural contexts. Everything that we do and all of the thoughts that we have are culturally embedded. I'm not going to be talking about the Indian context because that's part of the dialogue that I hope we will have afterwards, when you can respond to the experiences that I'm bringing from the particular perspective that you have. We could have the first. Oh, that's right. That's fine. As you've heard, I'm an anthropologist at SOAS, University of London, where I teach on culture and mental health. I'm also trained in the open dialogue approach to psychiatric crisis care and work as part of the NHS secondary community mental health team. And in the poster you saw me there with my lanyard, the NHS lanyard, where I work. Next slide, please. That community mental health team intersects, the open dialogue team in the community mental health team intersects with the crisis team, an inpatient team, an early intervention psychosis team. Next slide, please. This team is also in a culturally diverse part of inner London with significant disadvantage and mental health challenges. I'm also leading an anthropological study of the open dialogue approach in the UK, and this takes place alongside a large randomized controlled trial. And I chair a statutory voluntary sector multi-agency suicide prevention group in that same part of London. In this lecture, I'm going to introduce principles of open dialogue, firstly. Secondly, I'm going to illustrate its processes and effects with some cases. And finally, consider how an open dialogue approach might influence our approach to suicidality. So let me begin with some introductory comments on open dialogue. If I could have the next slide. Open dialogue is a, first of all, non-diagnostic approach to psychiatric crisis care. And that means that the encounter with patients in crisis doesn't start by defining problems in terms of labeling symptoms with reference to ICD or DSM diagnostic categories. Instead, practitioners respond flexibly to people's needs. They invite those in crisis and family and others around them to communicate about what has brought them to this point in the ways that are relevant to them. Practitioners take their cues, in other words, from the idioms and from the images, the silences and the body languages of those in the room. They encourage clients' own insights, personal meanings and frameworks of understanding, which may be religious as much as mental health related. Their understandings about what is happening to them in this crisis, the very things that are often ignored in usual healthcare systems. You could say that open dialogue focuses on what research has proved to be the key active ingredient accounting for variable outcomes in mental health treatment of all kinds, namely the therapeutic relationship. Open dialogue training certainly emphasizes practitioners' capabilities for presence, for listening and responding. It refines and deploys what are universal human capabilities for attention and empathy. The premise is that emotional exchanges between clients or family members and clinicians, and an emphasis on the present moment rather than some brilliant interpretation and intervention by the professional, are the key to new openings out of a crisis. To emphasize dialogue is to say that the interactions have to be two-way. It requires a response to client utterances from clinicians in their shared humanity, rather than the usual professional detachment. As Russian philosopher Mikhail Bakhtin, who has influenced open dialogue, says, "For the word and hence for the human being, there is nothing more terrible than a lack of response." Open dialogue is also a social network-based approach, and this means it views mental health within a system of relationships. People in crisis are encouraged to bring whichever relatives, friends, or others they wish to the so-called network meetings with open dialogue practitioners. Indeed, the dialogical process encourages multiple voices, those of the person, those of the family, team members, friends, clinicians. It encourages what's called polyphony, the speaking from many different points of view, on the grounds that the diverse participant voices and collaborative meaning-making are ways to reconstruct problems and find a pathway out of a crisis. And this contrasts the, what you might call, monological privileging of psychiatric expertise and diagnosis. The narrative approach which open dialogue draws on here involves the idea that human realities are constituted through language and communication, and that difficult experiences, including trauma experienced in the body that does not have words, can be reconstrued through a dialogical process. Emotionally engaged exchanges are the means to foster agency and social reconnection. So we aim to work with people in their social networks. But of course, the reality is that in many cases, it's the fragmentation of family and broken relationships and isolation and loneliness that have contributed to distress. So we may have to work relationally by bringing in absent people, the core relationships that people have in imagination, asking what would so-and-so say if they had been a witness to this interaction. Next slide, please. Now, there are some other core principles just to mention in passing, as well as the provision of immediate help at the time of a crisis instead of the common delays that we experience. Open dialogue requires team continuity through a crisis. The team members first in contact remain responsible for care as long as it takes, and wherever care is given, to ensure what's called psychological consistency. Instead of the usual experience of seeing countless different professionals and the re-traumatizing repetition of stories as people have to restate their crises. The approach requires flexible responses to people's need and also transparency. For example, by making sure that there are no separate clinical meetings outside of these network meetings with the person, no discussion or decisions about somebody without them being present. So open dialogue is both a new therapeutic model, but also a new way of organizing services. Organizationally, open dialogue involves a change in professional roles, in identities, and hierarchies of expertise. First of all, practitioners work as a team. There's a minimum of two, and the same ones meeting with people, two of us. Secondly, because the core capacity is to be present, deep listening, emotional responsiveness as a vulnerable human being, medical hierarchies of expertise are flattened. For sure, relevant expertise from a multidisciplinary team is available when needed, but with clients, doctors or psychologists avoid deploying their professional identity with its attendant power. The training that psychiatrists and others receive in open dialogue is, in fact, how not to know, not to interpret another's distress or immediately reach for known solutions, and so to tolerate the uncertainty that's involved in being present as themselves. Correspondingly, open dialogue opens up space for non-clinically trained practitioners. In the UK's National Health Service trial of what's called peer-supported open dialogue, all teams include people with lived experience of mental health services, either as users or as carers, who go through a common training. And these peer practitioners deploy their vulnerability and their resilience in the dialogical work. The complex challenges that peers face in the bureaucratic healthcare system would be a whole separate discussion, which we can talk about in questions if you like. But more generally, open dialogue requires of all practitioners the skilled use of personal experience and emotions in dialogical encounters, a sort of coming out from behind the professional mask. Because of its deployment of non-clinical staff in team-based practice, open dialogue offers potential for widening the reach of mental health care at lower cost, as a parallel to what's referred to as task shifting within global mental health. But the deployment of our vulnerable selves requires training and support. First of all, it demands a kind of cultivated self-awareness through exploring our own pasts, our families, our relationships as practitioners, so that we can anticipate how my emotional response to another's distress might be shaped. how I might, or how my response might be interfered with, or my ability to be present might be interfered with by what is brought up in me in that moment. Secondly, it requires a team process that supports and provides space for processing emotional responses to the work. And I'll come back to this a bit at the end. All of this is a rather radical departure from usual practice, at least in the UK's NHS system. And here Open Dialogue offers the provocation that the fundamental problem in mental health care is not with patients, but with the way professionals have functioned in relation to those in distress. Now I'm going to give a couple of suitably anonymized vignettes from my work to illustrate these processes. Slide bit. The first is a young man, Farid, who's been sleeping on buses and in parks and on the floors of his friends' flats. They worry about his self-harm and suicidal behavior, such as wandering into traffic or leaving the house at night in distress when waking from terrifying nightmares. He's referred by his GP to the Open Dialogue team, and we arrange a meeting asking where he'd like to meet and if he'd like anyone from his social network to join. Farid comes to a room in the hospital along with his friend Adil. We open the meeting by asking what's the history of this meeting? How has this come about? Or how would you like to use the time that we have together? Farid is obviously in distress, but gradually starts to talk about his current experience of having no UK asylum status, the threat of deportation, his terrifying nightmares, and his ability to go outside, or his compulsion to wander out at night. There's an unbearable tension, he says, that when his head is very hot and is going to blow, he smashes it on the wall to try to get calm. It tells us he feels useless, like a dead body. My female colleague, an occupational therapist, and I listen. We repeat back some of his own words and phrases and images. An idea from Bakhtin is that words repeated in the tone of a different voice are capable of interfering in the interior dialogue of a person, helping them to find their own voice. Each of us invites Farid to tell us more about what his experiences are like, what gives him relief. We focus on the here and now. He opens up more about his fears of groups of men on the street shouting, how news items with violence of war or bloodshed bring terror. And over the months that follow, we learn that he's suffered torture. He carries signs of mutilation on his body. He witnessed the killing of his father, and he's been abused. But we don't press for an account of any of this. He feels useless because, lacking asylum status, he's unable to work. He's no money and depends on his friends for everything, the shame and the guilt, and being taunted by some as a loser. We ask his friend Adil what it's like for him to listen to Farid talking to us. And he says how he wants to support Farid, but worries about him and looks out for him, and he doesn't like to leave him alone. We're keen to have as many different voices present in the room as possible, sometimes asking what someone not present, a friend, a relative, a deceased family member who's been mentioned, would say in relation to something expressed if they were here with us, eliciting some of the relational context of Farid's experience. At certain points, my colleague and I turn to each other to reflect on what we've heard in front of him. I say I feel upset by the distress Farid describes and the terrible experiences he's gone through, but also anger at the inhumanity of the UK's Home Office. We both validate Farid's experiences as understandable responses to an impossible situation, rather than focusing on symptoms. My colleague nonetheless wonders if he might benefit from specialist support for his post-trauma experiences. We both say we admire his strength and the goodness of his friends. Often in these reflections, we say how we feel on hearing Farid's story, what emotions are present for us, and sometimes what Farid's story brings, what emotions Farid's stories makes present for us, and sometimes what it is in our different experiences that these feelings connect to. So we respond as fellow human beings, not as clinicians. We ask Farid and Adil if there's anything they want to say after hearing us reflect. The dialogue continues at a pace and in an idiom set by Farid and his friend. We're exploring the meaning of his experiences. The meeting isn't driven by a problem-solving agenda, but when things arise for us to follow up, we do so. We're not making a diagnosis, say, of PTSD, but we do ask whether Farid would like us to invite a psychiatrist as a participant in our next meeting. He could continue to meet us even if he attended a specialist service. Or if his asylum case lawyer would like to join in the next meeting. The Open Dialogue Network meeting remains the key decision-making space. We ask Farid when he'd like to meet again and to reach out to us in the meanwhile, if he needs to. We continue to meet him, frequently at first, with different friends joining, and in time Farid tells us how good it's been to be listened to talk about the feelings inside, as he puts it, the painful things in his head, something he'd not done before, and how he leaves the meetings feeling lighter and happier. Putting his feelings into words with us means there's less compulsion for him to act out with self-harm, and he finds it easier, he says, to relate to others with less fear. He's not been labelled mentally ill, something he associates with fearful judgment of the crazy mental person. Later, when I interview Farid as part of our research, he says he got positive vibes from us because we were thinking he was the same human as us. There was still a long journey for Farid in the asylum system with his homelessness, his post-trauma experiences. His circumstances were not changed all at once, but he was able to give a different meaning to his experiences, to reduce the self-blame, and to have hope through validation of his struggle for identity, for a home, and for belonging. While our meetings are now infrequent, we remain available without formal referral. Now, sometimes people in crisis come to Open Dialogue who've been hospitalized under the Mental Health Act before referral to our team. My colleague and I meet a young woman migrant, Khadija, in the hospital and later discover just how traumatizing this experience was for her. The hospital system, including constant suicide surveillance, made her feel crazy. There, she couldn't speak about how she really felt for fear of the consequences. She was angry and just wanted to get out. Khadija was homeless, having escaped violence and abuse in the marriage through which she was brought to the UK from South Asia. She'd been shut in the house and deprived of outside contact until she fled to the protection of a women's refuge. Our team, myself and my colleague, a female nurse with the same ethnicity, continue to meet with Khadija as she moves from hospital and back to a refuge and onto a series of emergency and temporary accommodations through the birth of her child and the additional isolation of COVID lockdown. We meet her in places and at times that she chooses, weekly or fortnightly or less, and each time we ask how she'd like to use the time. She smiles and says she has nothing to say today. We sit, comfortable in the silence. But each session, she slowly talks about how it is for her now. And gradually, she herself makes connections between her present conditions and the life of her life of extraordinary deprivation and abuse. A childhood as a refugee, the tragic death of her mother, her rejection by other members of her family, hard labour and not being valued, always blamed and punished. Sometimes my open dialogue colleague and I hold our meetings while walking in the park, and we learned how Khadija yearns for the freedom of the forest of her childhood. Khadija is extremely isolated, marginalised in her neighbourhood by her ethnicity and her anxiety. She doesn't have relatives or friends to invite to the Open Dialogue Network meeting. Sometimes other professionals she works with, like a health visitor or the social worker, join, but our meetings always also bring in the voices of her absent relatives. What would they say? What would she say to them? We listen, we repeat her words. We say we're curious to know more about this or that. We reflect with each other on what we've heard, how we've been moved, and what resonates with us. We're brought to tears. We're not problem solvers, but fellow human beings. But of course, we do collaboratively set in train processes to ensure her accommodation, the start of education, and later one-to-one psychological therapy sessions with a colleague. Over 2 years, Khadija speaks about pain, and not a pain that not only had never been spoken, but which she did not believe could or should be put into words, certainly to strangers. At first, she later told us, talking was just reopened wounds, and left a trauma movie running in her head, as she put it. But over time, she said that through talking and hearing our different responses, and within the continuity of our presence, she made new meaning out of her past, so that she no longer blamed herself. A burden began to lift from her shoulders. Now, both Farid and Khadija are marginalized and made profoundly alone by wider social structures of poverty, patriarchy, race, border control, as asylum seeker, migrant, homeless victims of abuse, and their mental health is inseparable from these structures. Open dialogue was not about the treatment of symptoms independent of this power, but a means to help those individuals reshape their relationship to their distress as a meaningful response to power and its effects, and thereby to acquire more agency. They've reminded me of something Jerome Kagan writes in his book, Psychology's Ghosts. He says mental illness is about what has happened to you, but not only this, it's also about what it means, maybe a threat to your personhood. The patient's interpretation of events and the feelings that follow, not the events that a camera would record, are primary causes of most symptoms. The focus on the effects of power, often abusive, in people's lives and their response to the threat to their beings, and the meaning that is made and remade, suggests that the, next slide please, that the power threat meaning framework that some of you may know about is a helpful underpinning framework for open dialogue. And you can look at that later. The recovery for which open dialogue provides support isn't the neoliberal expectation of the independent, self-sufficient, productive individual. Certainly skills and education and employment support are part of what the service offers, but there remain significant barriers to the enabling conditions for decent work. What the safe space and the relational experience of open dialogue can hope to allow is the recovery of what Neely Myers calls moral agency. That is, the ability to maintain relationships, to be regarded as worthy by others, which is the precondition for work, self-help, recovery, and the capacity to connect to others. This is the kind of capacity building that I've also witnessed in the Banyans Home Again houses and the ECRCs. And as with the Banyans, in our open dialogue, peer workers play a key role in fostering such connections, or the ability to connect, as well as access to welfare services, especially where family support is absent or broken. Okay, I'm going to say something a bit more about the context of open dialogue in the UK. So if I could have the next slide, that would be great. Open dialogue has its particular context in the UK, where it's a response to some enduring problems in mental health care. Deinstitutionalization from the 1980s shifted mental health care to community settings, but so-called care in the community brought new problems and pressures. The reduction in inpatient beds alongside rising demand now places immense pressure on the community crisis and home treatment services that substituted for hospital care, and greater risk is held in the community. Next slide. This shows that as suicide rates in hospitals fell, they gradually rose among those in the care of the crisis resolution and home treatment teams. Next. Then there's the problem of repeating cycles of crisis, waiting, diagnosis, hospitalization, medication, abandonment on discharge, and return to crisis. No, just go back, that's fine. And the excessive resort to accident and emergency and compulsory admission. And the pervasive discontinuity of care. The context in the current UK health services is one of a service that is overstretched, very expensive, produces high staff stress, burnout and turnover, and there is widely reported poor experience of care by people using services. And such pressures account for an openness to innovation, in response to which open dialogue has been encouraged. Okay, now we have the next one. Open dialogue was first developed in Finland from the 1980s, especially in the work of Jaakko Seikola and his team in Tornio in Western Lapland, where non-randomized trials of the approach, we can have the slide, demonstrated remarkable and long-term stable success in the alleviation, so next slide, please, in the alleviation of psychosis symptoms and improvement in the quality of life, return to study, return to work, and lower levels of medication and hospitalization compared to treatment as usual. These kinds of research results attracted wide attention globally, and some form of open dialogue is now practiced in various regions globally in more than 24 countries. And the next slide, please. Including several in Europe, as well as Australia, Japan, Latin America and the United States, and of course here in India with the Banyan. While originally a public sector service, open dialogue has now found applications in NGOs and private practice. The approach has been recognized as a good practice example of crisis services promoting rights and recovery in the World Health Organization's guidance on community mental health services. The next slide, please. In the UK, as I mentioned, peer-supported open dialogue is introduced through a multi-site randomized controlled trial. The NIHR, National Institute for Health Research, funded development and evaluation of a social network intervention for severe mental illness, or a DESI. And while this trial evaluates standardized outcomes, time to relapse, hospitalization, recovery, and cost effectiveness compared to treatment as usual, there's a parallel study, an in-depth immersive anthropological study that I'm leading. And the next one, please. And this looks at open dialogue in its social, institutional and personal context across the varied sites, with a team of researchers who include peer and clinical ethnographers. The study is learning from practice so as to adapt and improve open dialogue in its different contexts. The results of both quantitative and qualitative studies are not yet available, but it's plausible to expect to find reduction in hospital readmissions and in the total inpatient days through adopting an open dialogue approach, and hence a saving in cost. We have qualitative evidence from clients and family members that open dialogue is seen as a game changer, as some put it. The experience of shared humanity and strong connections with practitioners being especially important, as is the safe, non-judgmental space for the previously unspoken to be expressed, and the value of flexible responses to needs. Eliciting multiple perspectives is often seen as providing people with insight into their own struggles and as creating more understanding from other family members by bringing them into the process. Staff too regard open dialogue as more effective, more ethical and safer than existing practice for similar reasons. Of course, there are also problems and challenges, mostly to do with the difficulty of fitting an open dialogue approach within the existing health bureaucracy and governance systems, or the resistances that open dialogue encounters. And we could talk more about those things in discussion. We'll be publishing a full account of the complex and context-specific practice of open dialogue in the coming months and years. Now, I said I would say something about open dialogue specifically as a response to suicidal distress. And I believe that an approach that emphasizes collaborative discovery of meaning rather than treating symptoms has something vital to offer suicide prevention. Suicide is the darkest of human tragedies, and finding a way through suicidal crisis is a priority in any society. Almost all of the clients we see in open dialogue have experienced suicidal thoughts or behavior. Disclosure of such experiences usually triggers the institutional response of risk assessment, with a view to crisis intervention and even hospitalization. Institutional risk prediction and stratifying patient risk, such as classifying people as red, amber or green, RAG rating them, is often informed by epidemiological risk studies. And this may involve statistical risk identities or behaviours, defined by national data, such as in the UK, associates suicide risk with, for example, middle-aged men suffering from job loss or relationship breakdown, alcohol use, and previous suicide attempts, or female victims of domestic violence or child abuse with histories of self-harm. The associations would be slightly different in India, where deaths by suicide are at a younger age, on average, an average of 20 rather than 40 years in Western countries, and proportionally more deaths are female, pointing to different roles and relationship pressures or notions of honour or shame and different kinship systems in the two contexts. In the UK, suicide rates are highest in the poorest and most deprived regions, but in India, they're highest in the regions with the fastest economic growth and the best education, health and other human development indicators, the southern states, including Tamil Nadu. In this region, statistically, suicide aligns with the combination of higher education and lower employment. There are distinctive age peaks for men and women in different societies, and factors such as marriage that are protective in one society and not in another. Alcohol is often identified as having a role as a kind of common pathway in suicide in different contexts. Now, such aggregate data have a tendency to shape the way individual deaths and individual suicide risk is read. Unknowable individual pain is given meaning in public narratives of suicide, which often turn out to be less about what explains suicide and more about what suicide explains. That's to say, suicide is an emotionally charged indicator of wider problems in society. And I don't need to belabor the point, but it's clear that ideas of suicide risk are highly overdetermined. This kind of knowledge, epidemiologically based knowledge, is valuable in treating suicide as a population problem, subject to public health rather than clinical interventions. Although, since there is an issue there's the issue that most who suffered the distress associated with suicide do not attempt to kill themselves, interventions always have to be very broad-based. We're not sure what it is that makes the idea of suicide available as a course of action for some in particular contexts, but not for most. Or how it is that suicide becomes part of a person's repertoire of pre-thought behaviours. The public health interventions at the population level that have proved most effective at reducing deaths by suicide are those that remove access to the means of suicide, such as changes in the gas in ovens or catalytic converters reducing the toxicity of car exhaust or the toxicity of pesticides, or controls on media reporting, because a contagion effect means that graphic reporting on suicide gives cognitive access, you might say, to the means to die in some vulnerable individuals. Despite effective public health measures, the evidence is that attempts to predict or stratify risk at the individual level are simply not effective. Next slide, please. Even though there are good reasons to be alert to retrospectively known antecedents of suicide. Sorry, the one before that? Okay. Yeah. Even though there are good reasons to be alert to retrospectively known antecedents of suicide, especially past behaviour of self-harm and suicide attempts, most who die by suicide, 85% in one European 11-country study, were classified as low risk at their last contact with services. People die who were classified as, the majority were at low risk. And this is what's known as the low risk paradox. People who are actually labelled as high risk die relatively infrequently. The people who die most frequently are those labelled as low risk. Alas, the idea that we can predict and intervene to prevent individual suicide is mistaken, and the assumption that risk can be known and controlled feeds a damaging culture of blame after suicide. Many people die having denied suicidal intentions in standard clinical assessments. Suicide ideation is anyway a vague notion involving, as Keith Horton and others say, a wide variety of degrees of intent, of motivation, of imagery and planning, and suicide risk continually fluctuates. Many may think about a suicidal act for 10 minutes or less before acting. I'm only too painfully aware of the failures of predictive knowledge and the awful self-blame that after suicide, because 13 years ago my 23-year-old son took his own life, a week after being recorded as low or no risk. The clawing question why forever haunts most bereaved by suicide, with the attendant "I should have known, if only this or if only that," when the truth is we could not have known. Scrawled over this determination of no risk in the doctor's notes, the clinician had scrawled father and brother as protective factors. It's as indescribably painful to realize that I failed to be protective as it is to discover those explanations and those warning signs that did not warn. Now, this isn't the place for further comment on this tragedy, although it is the reason that I'm here before you now. And it motivates me to insist that because we can know so little about suicide intention from the outside, we have to take expressions of suicidality as an invitation to an exploration, an open dialogue with people themselves. Unfortunately, too often, such disclosures of suicidal thinking provoke the opposite. That is, discomfort among clinicians who avoid in-depth discussion, change the topic, fear the responsibility that may fall to them by further disclosure of intent. And yet, current recommended approaches as set out by Horton and Lascelles focus precisely on developing a therapeutic alliance with a person who is suicidal, jointly assessing risk by taking time to explore the person's story, to understand their needs, their vulnerabilities, and protective strengths, starting with the here and now, and looking to the past and the future to understand the dynamic factors relevant to the present. The first point is that these various factors, such as a change or deterioration in mood or personal conflicts or past experiences of self-harm or suicide attempts or early childhood adversity or any others, only become relevant when they are given significance to the present crisis by the person concerned as part of a validating collaborative narrative. The second point is that this narrative needs to explore suicidality in itself with an open-minded curiosity, considering the motivation and the meaning of dying to the person and what suicide for them could accomplish. You might say the functional utility of suicidality to a particular person. This is the approach of the collaborative, I think next slide please, the collaborative assessment and management of suicidality, or CAMS, that specifically targets suicidal thinking for assessment and intervention rather than mental health. And there's an important shift here away from the still dominant approach of regarding suicide as a symptom of psychopathology within an illness model. The person who needs to be fixed. The problem with this, and the clinical view of safety generally, is that this can lead to a disowning or dismissing of the self that is being expressed through suicidal thought and behavior, as Matt Ball puts it. And we miss the way suicide may be a desperate act of survival of the self. A collaborative approach such as CAMS aims to help a person identify what it is that makes suicide a coping response. A question might be, a lot of people struggle with X, but not everybody who does so wants to kill themselves. How are you seeing X, the situation, that makes you feel suicide is an option or the only option for dealing with it? The person is facilitated to find the indirect or direct drivers of their suicide, the background issues, maybe the marital or other conflicts or homelessness or whatever is happening, and the immediate experience of internal pain or particular behavior, to find themselves the risks that can be modified and to form a plan around these. As Dr. Ian Gallivan, from whom I draw here, says, the risk assessment here isn't to predict client behavior, which can't be done with any useful accuracy, but rather to shape clinician behavior, to collaborate on a plan around modifiable risk. The collaborative method of CAMS has extracted into a manualized form what is a broader orientation to suicidality captured in a suicide narrative approach developed at the Humane Clinic in Australia by Matt Ball and others. They emphasize that the one who is contemplating ending their life is not just a patient who needs to be fixed, but a person who has a rich narrative on how they've arrived at the insufferable reality of suicide. Someone who is suicidal is also wise. A deep form of listening and human-to-human connection is needed to discover the meaning of suicide, the emotional wounds, the trauma, the oppression, or the spiritual crisis that reveal how it is that life has become unsustainable, and the phenomenological, maybe the bodily reality of the distress. The suicide narrative theory is that suicidal thought involves extreme or altered state that is a response to a threat to the self from particular relationships or particular kinds of circumstance. It's a response that involves dissociation from that threat, going into a space beyond the capacity to cope. In other words, experiences of suicide in a person's life should be treated as important and meaningful. Just as it's better to explore the meaning of hearing voices than to label them as symptoms of mental illness, so suicidal thoughts are opportunities for the exploration of suicide's functionality, what it means. A clinical response that preemptively tries to remove the suicidal thoughts without supporting a person to explore the meaning and purpose of that suicidality with curiosity and openness, something Matt calls a suicide meaning conversation, Matt Ball that is unlikely to help. As in open dialogue, the aim of a suicide narrative is, as Matt Ball puts it, to change relationships with the origins of distress, rather than simply seek to deny or get rid of the experience of suicide. The suicide narrative approach also stresses that suicide isn't just a problem of an individual. The suffering of a person who is suicidal carries a message about or bears witness to suffering in the wider social environment. A person might find connections between their distress and the wider structures of poverty, abuse, discrimination, inequality, or violence. Taking a person's suicidal state seriously, having a dialogue with suicide, requires that we go beyond an illness model and explore the insufferable human condition that suicidality speaks to. It should be emphasized that while exploring meaning behind suicidality, none of these collaborative or dialogical approaches ignore the need for immediate responses to keep a person safe, for example, by removing the lethal means and collaboratively developing a safety plan. But what is at the center of creating real safety is the open-hearted, intentional human connection, something at the center of things like emotional CPR. Now, listening to people and responding with authenticity isn't rocket science. So why is it so difficult to put in place? And why do so many suicidal people say they were not listened to? Many times the protocols around risk assessment and risk stratifying and risk management make it hard to create space for suicide narratives. The core of the problem is that in practice the risks being managed are not those of the vulnerable person who is feeling suicidal, but the risks to staff and to the organization. Risk assessment and the fantasy of prediction create a culture of blame and anxiety around suicide that has pernicious effects. The chaplain of a particularly notorious cliff for suicides in the UK said the following: "To help a truly suicidal person, you have to approach them with an open heart. If you're worried about the risk their action poses to you, they're more likely to jump." Open dialogue aims at this open-heartedness, but open-heartedness needs to be sustained by an organization. Generally speaking, staff find that the open dialogue approach immensely rewarding and even transforming. But to be emotionally present and vulnerable with clients, to be open-hearted in face of distress, is also very emotionally demanding. It requires a reorganization of existing mental health teams so as to provide mutual care and shared responsibility. It means prioritizing reflective spaces and self-work. My open dialogue teams processes do, to a degree, focus on mutual support around the emotional demands of being open to the distress of another. That's the purpose of our so-called 2-hour weekly intervisions focused on our emotional selves, not the client's situation, because all decision-making related to the clients takes place within the network meetings with them present. But keeping and expanding such practice, given the wider organization cultures of healthcare and public mental health care systems, is extremely challenging, especially where ordinary healthcare practice involves procedures and protocols and even everyday language that effectively creates distance from clients and their distress, and involves often those unexamined processes of counter-transference. Open dialogue involves a depth of culture change that may require nothing less than a social movement to accomplish. The wider and more diverse the network of open dialogue practice becomes, the more resilient such an innovation may be. And that's why it's been so good to connect to the Banyan and to BALM here. Thank you for your attention.
We learned a lot. Thank you, Professor David. So now we have some time for Q&As, reflections, questions that you'd like to ask, your experiences that you'd like to share. So over to the audience.
So this institution has different disciplines, including management, psychology, social work. So open dialogue, is it a technique which can apply only in the kind of setting that you shared, or do you think there are other places also we can apply?
I mean, there's nothing exclusive about the fundamental principles of open dialogue, the capacities to listen, to be collaborative. Open dialogue implies a kind of democratization of healthcare systems, and democratization are processes that are potential in any organizational setup. So you can certainly think of what would dialogical leadership look like, and what kinds of accountabilities would that put in place. There is a tension always, however, between the kind of embedded structural demands of bureaucracies and systems of accountability and the expectations that open dialogue has on being open, on being flexible, and so on. So open dialogue is a bit like those moments of the anthropologist Victor Turner used to talk about communitas, where there's a sort of release of some sort of more fundamental expression of our humanity, but that always gets, that anti-structure always gets kind of restricted by the structure, the structures into which it is placed. But in principle, there's no reason why open dialogue shouldn't inform other kinds of processes of democratization.
Might be a silly question, but you said that you meet with the person. You meet with the person,
yeah.
And I was wondering if you had like a time restriction on the first meeting, or if it goes on for 6 hours, it goes on for 6 hours, and then the sustainability of that.
Okay, that's a very good question. There is no restriction. So we meet with a person for however long and wherever they want to meet. And sometimes in a moment of crisis, it may be that a longer meeting, it may be a 2-hour meeting that is required. The argument, and we'll see whether the quantitative evidence demonstrates this, is that you may start by making those meetings available to people without restriction and without rationing. Actually, people make less use of that service than if they were told, it's 50 minutes, the psychoanalyst 50-minute slot, and that actually matters resolve more quickly. And so you might start with a high level of intense engagement, but it drops off much more sharply. And so in the end, you use less time working with somebody than if you tried to keep it at a sort of limit and over time. So that's the theory and the expectation. And we will see to what extent that's borne out with the evidence of the research that's being done.
This is more of a reflective question. I feel like open dialogue is asking for an interaction of open heart and deep suffering on an everyday basis, outside of the therapeutic setting of what it might look like. And you mentioned something about the need for an organization to also take ownership in enabling that kind of an environment. Now, thinking about this in the Indian context, especially Tamil Nadu, where a lot of death by suicide happens in educational, just born out of educational spaces, especially in the time of 10th standard, 12th standard, entrance exams. I'm now trying to see how do we imagine a space where we can engage with that conversation of deep suffering, of suicide, of suicidality, and how do we imagine a space where we can nurture that conversation and engage with that? Is there something that we can learn from, or how do we start picturing this? Is a thought and a question that comes to my mind. Yeah.
I think maybe the starting point is to think about what are people currently doing? What is the current approach to preventing suicide and managing risk? If the institutional response is to remove ceiling fans and put bars on windows and to put people under intense surveillance, but without actually having the opportunity for people to be reached and to have conversations, it suggests that you're in the mindset of risk management rather than being open-hearted. It's not to say that action for the prevention of means isn't important. I've said at a population level, that is very important. But if the institutional focus is on managing risk, possibly for its own reputational benefit rather than for to meet the needs of somebody who is vulnerable, then you're closing off the opportunities to have those conversations and maybe making it more unlikely that somebody who is in distress will actually think that such a conversation is possible. Because one of the things that people who are suicidal often say is that this is a deeply private, personal matter that I couldn't actually talk about. They would be embarrassed and afraid because of the response, primarily because of the response that they would get on expressing suicidality, rather than, I'm curious, let's talk about that. Let's open up that box. It tends to close things down. And of course, the anticipation of that being closed down is extremely dangerous because it locks suicidal thinking inside a person where it can breed and become acted out.
Sir, wonderful session and thank you. Can you expand a little bit more on how the clinicians can actually change their behavior in view of responding to the suicidal distress?
I mean, what I've said is, I don't want to just repeat, but having time and being curious and being open, rather than locking down into a sort of protocol of risk management, is one thing. I think that I've experienced some extremely poor clinical practice in the UK, where somebody in distress meets a psychiatrist, and the psychiatrist is hardly looking at the person and doing a checklist. How often do you have suicidal thoughts? Going down a checklist, ticking things off, and if the person could simply, the clinician could simply be present with the person and their distress, that would be a tremendous start. Setting aside the protocols. Sometimes people say with open dialogue, well, if you just have this open conversation with people, are you going to be asking the questions that are necessary for a risk assessment? Are you going to make sure you ask the questions? Well, it turns out that by having this unstructured, open, client, person-led conversation, actually you discover not only do you cover the questions that will be there in a standard risk assessment, but you find out much more about the circumstances of a person, and you can have a much better idea of the risks, and you can involve more voices and opinions and views because you've got other people present. So I think I don't know if I'm answering your question, but I'm suggesting that operating in an open dialogue way is actually safer and more compliant with even the narrow understanding of what professionals are expected to do in terms of identifying and responding to potential suicide or self-harm risk.
So as an organization, a lot of lay people also reach out to us following a post on social media. And so spontaneously as an organization, we're responsive and then we try to reach out to them. But sometimes people prefer to remain anonymous in terms of expressing their views about they want to access or they want to seek support. But at the same time, when we try to reach out to them, there's a little bit of peekaboo that goes on between us and that individual. But on the other side, as a practitioner, what you're also trying to do is there is some amount of pressure where you're thinking maybe this person is in a lot of distress. We want to reach out to this person. He or she engages for a while and then disappears for a few hours or for a day or so and then reappears again. So how do we go about this? Because there's some amount of, emotional pressure that you also go through in terms of you are being responsible as an individual for a person who's in distress. In addition to this, as a practitioner, sometimes you know what needs to be done, sometimes you don't know, but still you want to reach out to this person. So how do we go about it when there is so much of anonymity in terms of how to go about this person is not willing to come in person, or this person doesn't want you to come in person and reach out to this individual. So how do we go about it?
Thank you. That's a very pertinent question. Although it comes from your particular context, I recognize it from other contexts. Can I just ask, who is the us in this? What's the organization?
I mean, any organization who's reaching out.
You were speaking from particular experience.
Yes, I'm from the Banyan. So
the Banyan. Okay.
Yes.
Okay. There is always an important place for those anonymous, extremely anonymous, confidential helplines, and I wouldn't suggest in any way that shouldn't be available. And the confidentiality of those helplines is important. It does place an emotional demand on somebody who is listening to somebody who is in extreme distress, and the not knowing of what the consequences are when the phone call ends, and not knowing what's going to happen. And I don't think you can manage that unless you have a proper A, training, and B, you have a team around you so that you're not personally taking that responsibility and recognizing that you cannot be responsible for the actions of another person. You can be responsible for being available, you can be responsible for listening, but you cannot be responsible for the actions of another person. And I think good training and support around would help someone in that situation understand what where you have to process and put those feelings of responsibility. They are the things that even if people are working face to face, keep mental health practitioners awake at night. And that's why the burden in mental health care is so great. But usually it's because it's often in mainstream systems, it's unattended to, and therefore people don't get the kind of support that's necessary. The question of extreme confidentiality is a difficult one. It's a controversial one because, there are organizations like the Samaritans in the UK that have changed their policy from being extremely and utterly non-interfering to saying, well, if somebody is really in distress, they will try to ascertain the details of where somebody is, and they will provoke an intervention to save somebody's life if they feel it's in imminent danger. And there are some people who think that itself compromises the importance of that anonymity and confidentiality. But as I said, I think those kind of spaces are important, but so is the support of people who work in those those helplines.
Another question, Dr. Open dialogue is a recognized intervention now.
Yeah.
Now, if you have to apply this to an Indian context, where mental health care occurs at different locations, institutions, primary care, then in the community. With this being a time-intensive program, how do you think this will become implementable in Indian context?
Okay, I think that's a really important question. The first part about the time intensity, I sort of answered in relation to think about the time span. It may be time intensive at one moment in order to be not time intensive at a later time. The other question is whose time? So the time of a trained psychiatrist has a greater burden in financial terms than the time of a volunteer or the time of somebody who's not clinically trained. I think there are certainly problems in the way that we hierarchically reward unequally people who have experience, who have expertise from experience. But setting that discussion aside for the moment, if you think about whose time, there is a potential for open dialogue to actually make more time available, but not necessarily at greater cost to an organization, because you're not making more of the highly qualified in clinical terms time. And therefore you can actually say, by inverting the normal view of expertise and say that the priority expertise here is fundamental capacities that we all have as social animals to be aware and conscious of and to relate to other people. And we prioritize that. These are skills that are much more widely distributed than the specific expertise of medical or psychiatric training or psychological training.
What about the extent parenthood that are the executive salt?
Can you explain what you mean by checks and balances?
So says that if you by a tactic and a part of us and we participating if there's
Yeah.
what we know it will what is the flag that we should be aware of and so on. Red flags.
Red flags. Yeah. Well, in the way that we practice open dialogue we do so as part of a multidisciplinary team. So there is always expertise available, but you may not be using it. So for example, there are psychiatrists and other specialists in our team, but as I mentioned in the example I gave, we might decide to call in a psychiatrist to come and join our meeting if we have particular concerns. It doesn't mean that person needs to be there all the time. They may be there just for one particular instance, or there may be some particular issue that comes up. Maybe somebody we think maybe it would be helpful for somebody to talk about the possibility of autism or of ADHD or something else that might be going on, that we have a hunch is, and then we can bring somebody in who has that expertise. Doesn't mean we all have to have that expertise. So in a sense, it makes lighter use of those relevant expertise. And of course, when those experts come in, if they're open dialogue trained, they come in as equal participants in the network, but they have in their back pocket a lot of knowledge that can be deployed where helpful.
Professor, I'm really curious about the documentation process.
Sorry?
The documentation process.
In principle, the documentation process follows the same idea of nothing about us without us, so that all medical records would be agreed and written collaboratively with the patients, the family members concerned. The time constraints, a bit of reality, mean that's often quite difficult to do in practice, because you don't want to extend a meeting by going through another half an hour of agreeing what to write. So the documentation, we tend to be brief in our documentation. We don't record details, write extensive notes about somebody, their conditions, their symptoms, and so on. We will say in our documentation, we met, who was there, what were the issues that were discussed, and in our documentation we will say, were there any particular things of concern, so that we will if there's a risk concern, we will have to document that, and then there's a plan of action. What's the next thing? But they're much briefer than other forms of documentation than you would find. But they do have to meet the basic, because we work in a public sector, government health service. We have to meet the basic documentation requirements and record keeping.
Professor, I have my head is spinning with a few questions, but I'm trying to make it brief and put it in a consolidated manner. One is, from what I understand, you have co-therapists in the process of open dialogue.
Yeah.
The process of open dialogue. So the one question I have is, what happens if the two therapists are in conflict about, a client, who you're seeing? How do you resolve that? You do have reflections in front of the client and all of that, but what if there is a genuine conflict between you and the other therapist in the process of trying to help someone? How does one resolve? The second question is a very fundamental question I'd like to know is, what are some of the ethical dilemmas that an OD practitioner, encounters in their practice? And how do you resolve that as well? Some of the common ethical dilemmas.
Okay, very interesting question about conflict. And I'm going to tell you what the principle is, and then I'm going to tell you some of the practice, because they're not always the same. In principle, difference of opinion is regarded in open dialogue principle as a positive thing. In other words, different points of view, even if they're disagreements, are positive. You would express them in a network meeting, and we do express different points of view. It's likely that if there is a serious difference of point of view, and people are feeling quite sort of worked up about it, then we would want to bring that to our team, what we call intervision, not the supervision, but the intervision. And we would say, look, I felt really pissed off with you because you were saying this, and so we would have a space to work that out in a way, elements of that would not be helpful in front of the client. So there are elements which are to do with our feelings, our relationships with teams, which also have to be worked out in the intervision space that we have as a team. And these intervision spaces are actually quite fascinating. I mean, in a sense that they are changing the way teams work. They require a kind of openness and a trust, which is quite difficult to establish and maintain, but when it's there, it can be enormously productive, because it means people can be honest about what they're feeling about each other. These are structured meetings. They're not just like free flows anybody can talk about anything. What the Intervision, these 2-hourly sessions we have every week do is they replicate the structure of the Open Dialogue Network meeting. So you have the center, you have 2 or 3 people who want to bring a concern, an issue that is bothering them, and then you have a reflecting team around the outside who will listen and then reflect on what they've heard, and then it will go back to the team in the center. Now, I'm not saying that it's always and all conflicts are easily resolved. They're not. But you have a bit of a space to begin to work through things that otherwise would just not be attended to. It's not perfect, it's not utopia, but it creates opportunities that otherwise aren't there.
And what are some of the...
Oh yeah. Well, just give me a bit of a clue as to what you're thinking about, because there could be many different sorts.
All the bees that in a position.
Yeah. 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 Yeah.
The people of the bar think ethics.
Yeah.
Non-dual relationships. Through those kind of things talks with.
Yeah.
What?
Well, I mean, I think one of that there is a lot of blurring of boundaries that open dialogue practice potentially involves. And one of the issues is that the training in open dialogue encourages people to disclose their feelings in relation to those they're working with. Now, that doesn't mean that an ethical dilemma would be, okay, I'm feeling quite intense about this person, what they're saying in their distress, because I know why I'm feeling distressed, because this relates to something that has happened to me. Some trauma, some tragedy, something's going on in me. So I can say to the client, look, perhaps in our reflections with colleagues, this is really quite stirring for me. And I can say, well, I'm feeling it, and I can say where in my body I'm feeling it. But I would not disclose private information about why I'm feeling that. Although in some clients, I have at certain point in our journey together, because it seemed ethically wrong not to not disclose things that maybe something I had experienced in life that I shared with a client. Now then you've got a dilemma, because the more you share, the more your client becomes like a friend, or the more your client treats you as a friend. So can our clients be our friends? I don't think there's a single answer to that question. And it's a sort of thing that is a dilemma. In my case, it's even more complicated. We have a research project. I'm also an anthropologist. I'm also an ethnographer researcher on top of being a practitioner and being a person who has those things. So there are dilemmas that are related to the research element as well as to the clinical practice element as well as to the first element. So I think some of the ethical dilemmas are about boundaries. What's interesting is that the boundaries, the dilemmas faced by me are different from somebody who is clinically trained, and different again from somebody who is hired and employed as a peer worker, whose specific role is to be alongside somebody, do things with them, take them to the shops, go to the swimming pools, try to build up that companionship. Befriending is the task of peer workers as well. So it's not, people in the team will have different kinds of boundaries. There are boundaries around an ethical dilemmas around the formal system. If somebody's, when you might have to invoke the Mental Health Act, or you might be part of a process that's going to section somebody, or maybe even lead to an imprisonment. Your alliance with the person, and yet your duty and obligation as a professional are torn. Sometimes it's clear what the right thing to do is, but your heart, is pained because it's not an easy decision to make. So there are different kinds of dilemmas, and they're certainly made more complex by open dialogue. There's no question about that. There are probably more dilemmas as a consequence of trying to do what most people would agree is good ethically good practice.
And
What is the cost implication of practicing the local diet?
Do you mean financial cost? Well, one of the DESI trial, the large-scale randomized controlled trial, one of its criteria is cost effectiveness. So it's not simply cost that matters. It's does that cost produce commensurable, better and positive effects? So you could have something that was low cost but low effective, and you wouldn't want to save money in order to be ineffective. So if you're spending more, but it's more effective, and on balance, the days of people being, the most expensive part of the mental health care system is people being hospitalized in tertiary care. That's incredibly expensive. If you can reduce by half or a third, 2/3 or more, the time that people spend as inpatient in hospitals, you've saved a massive amount of money. And so if you look at cost effectiveness, you would have to take all of those things into account. You're not simply tabulating how much is cost in terms of time, hours of members of a particular team. You take thing in the round.
If you a low cost producer
Can do, not necessarily, but can do.
Yes. What is the average about every and administrative group size approximately what the bar implicated so that I can make the service available for the people who require it. So what approximately is the cost was, for example,
Well, I can't tell you that. That will be part of the, as I said, part of the evaluation of open dialogue in the large trial across different sites. But I can't tell you now what the average cost of open dialogue. See, in the randomized controlled trial, you have people who are recruited from cluster randomized GP practices. So it's a cluster randomized trial, which means you have a cluster of GP practices, primary care practices here, and a cluster here, and everybody who is in crisis by the triage scale of the National Health Service will be offered open dialogue from these GP practices, and everybody in these GP practices, the control, will be offered the treatment as usual. So there will be a means by which you can monitor the time spent on both arms of the trial and look at the outcomes and make those comparisons. The people doing the quantitative research are very careful to sit on their data until the trial is over, because they don't want to mess up the results with feeding back information that will disrupt the randomized blinded elements of the trial.
So thanks, Professor Mosse, for a very insightful lecture, and also for sharing your personal experience as well. So I have 3 questions. 2 are practical, so we can go through those quickly. But the slightly deeper one, I think we did touch upon that in our previous conversations. When we talk about unbearable suffering and about death by suicide, and we also associated it with a sense of deep insight and wisdom, at what point does one actually let go or collaborate with a person who isn't in a position to continue with life as a consequence of unbearable suffering? Because I know that we are speaking a lot about prevention. We are talking about people in India in particular in the productive age groups of 15 to 29. And therefore we are concerned about it. And we do speak of emotional regulation and impulsivity, and therefore we want to address those issues. And indeed, systemic barriers such as caste, class, and gender-based discrimination. But if it's psychic pain and emotional pain, and if it's from deep within, and if it's unbearable suffering, as clinicians and as human beings and as open dialogue practitioners, when do we say, no, this is just too deep a pain, just like you would in the case of persons with a physical ailment?
I hope that's not the practical question, and the others are more profound. Because that is a profound question, and it's not a question that I have an answer to, because I don't think. I mean, institutionally, you can't ever have a situation where you let go. Institutions will not allow people to be let go of, for the simple reason that there is no point at which you could make a judgment about whether the experience that somebody has is a forever experience or whatever. There is no point that wouldn't be subject potentially to abuse, that you could say that the obligation to protect and to prevent, to save life, to prevent death is kind of absolute. Of course, the cases go to court when people are on life support and all the rest. This is a contested boundary. It's absolute, but it's still highly contested. And I think that it's a very, very hard dilemma. I think people will probably come to it from different angles depending upon their personal experience, what they have experienced, what losses they've experienced, what life experiences they've had, about and the capacity that people have to empathize with what that means, what that pain means. So I'm really going to have to say that I can't answer that. I can appreciate the question, and I have the question. It resides in me as well, but I don't have an answer.
So the other two questions I had is around sectioning, and when as clinicians you engage as an open dialogue practitioner, and you do realize that the person is in need of perhaps acute care in an institution for a brief period, and the client isn't really willing, or for that matter, a homeless person on the streets. How would you address that typically, and what sort of a time frame would you give? How would you balance care with rights and sort of the whole pivot around open dialogue of collaborative care?
Yeah. I mean, again, there's two things. There's what happens before sectioning, there's what happens after sectioning. The question was, as far as was humanly possible, the discussion about sectioning would take place in a dialogical way. So you would have the relevant nurses and qualified practitioners who are responsible for making those, for signing off somebody into section as part of the discussion, and family members. It may be that in the end, in that meeting, you have to do what you don't want to do, which is to say that we've heard what you said, but actually we cannot find another way to keep you, whatever it may be, safe or whatever, than a period of hospitalization. So it may be that you are making a decision in the end, which is not a decision that the person you're working with will agree to. The point then is that that's not the end. Then, you will go and meet that person in the hospital. You will continue to have those meetings. You will maybe talk about the conditions, about the sectioning, about whatever that person is willing to be able to talk to. Often people in their sections are often actually not, you're often dealing with people who are highly distressed, who are not kind of conversationally available. And so it may be a different kind of conversation. But the point is, the continuity of care is important. You're not saying, in being sectioned, we are abandoning you. You're saying, we're still with you, and we'll go with you. And so I have open dialogue sessions in hospital. I have open dialogue sessions in the seclusion room. Admittedly, you have 6 burly nurses there ready to sort of trigger the massive restraint operation, there. But you still do it. Even in prison, through a hatch, where you're not allowed to be with somebody, you can still have a dialogical process. The principle of open dialogue is you go with someone, you stay with someone wherever they go, and if the system means that's where they have to go, that's where you go as well. So you can't necessarily stop it. Certainly, if there's a matter of law and imprisonment, and you can't undermine that, but you can be with through the process.
The last question is about peer specialists and the training programs that you have for peer specialists to be open dialogue practitioners.
Yeah. Well, the peer specialists go through the same training as I or other people do, but the way they're the way the trainings are organised is there are opportunities for people to come together as peer specialists and kind of think through the particular issues they have. There's also increasingly, certainly within my mental health trust and others, there are kind of organisation arrangements now. There are sort of peer leadership roles that create pathways for people to become more skilled, to have further training, to become more expert within peer roles. So it's happening now. One of the problems with peer roles is that it was a sort of, there were glass ceilings everywhere. Once a peer, always a peer. You can only be a peer. That's it. And you can only live with a sort of re-traumatizing experience of But actually, it's recognised that there are many. You get as a clinically trained doctor, you gain status and rank and financial reward for experience the longer you're in the system. Why should that not also be the case for somebody who comes into the system on the basis of lived experience? They're also gaining increasing skill and expertise in deploying and knowing how to use their experience, and also training and making that available for other people. So there's opening up the possibility of those sorts of pathways of enhanced skill and reward. It's something at the beginning. It hasn't really, it's kind of just getting off the ground. Other countries are much better at it. The Netherlands, for example, has whole kind of colleges of peer support workers. You maybe know about them, and they're much more sort of sophisticated in their treatment and understanding of peer roles. To some extent, I think there are parts of the US as well. So we're kind of playing catch up to some extent on this. It's a really important, valuable field. And in my research team, I've got 4 peer, 3 peer research practitioners who are also researchers, because bringing people with lived experience into research is as important as into practice.
Then and the peer specialists that was part of the edit.
Yes. They're employed. Although this is the problem, is they're banding in terms of the scale. They're often banded at a low level. Now they're beginning to create higher bands for. I'm still way below the doctors, but they're still trying to create slightly higher bands as people can get experience, rather than everybody being on the lowest sort of band. So yes, these are people with NHS contracts.
I have 2 questions. One being, this might be a very rudimentary sort of question, but when you say open dialogue as a response to suicidality and suicidal distress, what do you think becomes the stance of somebody who's practicing open dialogue? In the sense that I heard you say a lot of things relating to the agency of this client that you're working with being the most important. At least that's what I took away. So in that sense, what do you think your hope as an open dialogue practitioner becomes for this client? Is that something that you have to keep in mind when you're working with someone like this? And the other question is, as a early sort of beginner mental health practitioner, I've struggled a lot with suicide risk assessments while working with clients myself. But I also feel like there is a sense of, I wouldn't say structure, but there's a sense of something to fall back on and rely on when you're working with suicide risk assessments or safety planning with clients. So how do you think that's something that can still be incorporated when you say that, we need to move sort of beyond suicide risk assessments? Because I agree with them, but it's sort of like I'm still sort of in between.
Okay, I'm really glad you raised that. I'll come back to the first question, which I'm a bit less clear on. But let me make it clear that the argument is not that you shouldn't work with people to assess the extent of their suicidal thinking. It's just that is never going to provide you with the ability to predict. It's the negative judgments that are most dangerous. This person is this person is at no risk. This person is green, not amber or red. In a sense, everybody needs to be treated in a sense, you can't stratify. So it doesn't mean you don't do it and therefore nobody pays any attention to anything. That's absolutely not the case. It means everybody pays more attention to everything, but does so in a way that is more engaged than simply thinking that you can establish, you can forget these people because they're all green, and you can focus on the reds. And this is what people do in community health. But say, okay, we're going to meet. We're going to look at the reds because the greens and the ambers, they're okay. That's not a helpful or a sensible way of going forward. And I was going to say something else about that. Just dropped out of my safety planning. Of course, safety planning is important for everybody. It's not saying don't do safety planning. On the contrary, safety planning, collaborative safety planning, it's an essential part of open dialogue in our service. We talked about documentation earlier on. One of the key documentations that we have to do is to collaboratively develop a safety plan, to work out with people what are their, if ahead of time, what are the things that are a sign that things are becoming a bit wobbly, things are becoming difficult, that you might not be safe, you might be in peril, as one of my clients refers to. And then you talk about that and you develop it and you say, well, where is the support? And so you've got that and you've done that. It actually has to exist on the system as well. But the point is existing as a record that somebody has with them. And that's something that you don't only do safety plans with people who are got red lights. It's a much more. So it's not about. It's the categorizing, the stratifying that's the problem, not the identification that there needs to be something that we pay attention to. That's really, really important to be clear about. The first question, I don't know if I've kind of got it, but you're talking about agency. You're talking about. I don't know whether. What I was thinking about when you were speaking, which may not be the same thing as understanding your question and answering it, is that I was thinking that we're dealing with agency, but actually we're often dealing with our clients with meaning ahead of agency. So to try to understand how it is that people are thinking about what's happening to them and what's the basis of their actions and their agency. We can't do for people, but we are available to work through some of the significance and the stories that people are telling themselves and that can change. And if those changed narratives or stories or forms of meaning can also enable different kinds of agency as a consequence of that process. So, but I'm not sure that is an answer to anything, and I'm certainly not sure whether I answered your question.
Not just in the discussion or dialogue that you're having with them, but what do you think becomes something that you're looking for? Like, is that something that you have to keep in mind? I think like what Dr. Vandana was saying, is it only about, I have this particular intention or aim of doing this with the client today, based around obviously what they want to talk about or what they are hoping for themselves. But beyond that, is there a certain kind of stance or, something that we need to work from a particular lens? I think I'm not sure if I asked the right question.
I mean, I think one of the beautiful, important things about open dialogue is it doesn't have rigid ideas about what an outcome is. And I think often we talk about outcomes, like we know what's the outcome, it's the reduction in symptoms of X, or it's the. But with an open dialogue, we can be much more open about what is a good outcome. What do you want an outcome to be? What would be meaningful for you as an outcome? And that will be variable. So it's the process towards defining an outcome, rather than saying, this is the outcome I want for these people, because everybody has different wishes and desires in life, and I couldn't possibly dream of telling people what a good life would be for you. So you work to think about what an outcome is, and the outcome could be quite different. It could be a resolving of a certain set of relationships, or a change, or it could be acquiring somewhere to live, or it could be there are lots of different things that feed into that. What is an outcome? But it's a process to realize that there is not a rigid set of outcomes. Some outcomes are obvious. I wanted my client to get recognition from the Home Office that he was a legitimate asylum seeker and he should have the status. I'm happy to say now that he did get that in the end, and that did more for his mental health than anything. If they could randomize controlled trials on giving people asylum status, that will come out with outstanding results, and everybody will be prescribed proper status in the country in which they live, because that has more benefits in mental health than almost anything else we could do as clinicians. So that was definitely part of what was a good outcome for him.
Thank you, Professor, for the wonderful lecture. So I don't know whether it is a question or my thoughts I'm putting into the words. Looking at the topic, suicidal distress, while working with the vulnerability and marginalized people. So, if you take Indian context, socio-cultural values plays a major role in terms of suicide. For example, you take, 2 days back, there was a IIT, in IIT Bombay, there was a Dalit student who committed suicide. In Hyderabad Central University, you might have written on Rohit Vemula's institutional murder. And if you take LGBTQ issue, why their people are committing suicide? Because it is not the personal stress or personal unbearability, whereas it is rather the society. It is a society who force them, which society plays a major role or force them to commit suicide. In colleges, it is not an individual problem. As long as we have talked about an individual person, but here the problem is the society and cultural values. So how do you look into it? Thank you. And what happens, the same social and cultural values reflecting in not only in the academic institutions, whereas it also reflects in the mental health institutions. If you look at the people who are working in the mental health institutions, how many are from the background, how much are they understand the issue or empathize the people from the marginalized communities. And these are all few questions I would like to you to respond. Thank you so much.
Thank you so much for the question. That's why I said in the lecture that if you adopt a dialogical and a narrative approach, you recognize that suicide cannot be treated simply as an individual matter. And if you explore with somebody who is feeling suicidal, what is it in the context, in the situation, then you may have an opportunity to find out the connection between the suicidal thoughts and experiences of distress and the wider context in which people are. You're absolutely correct, in my view, that the cultural environment, the forms of discrimination are powerful determinants of some of the things that we know from wider research on suicide are important. The kind of experiences of entrapment, the experiences of humiliation, the experiences of rejection are particularly pernicious and powerful thinking more generally. And if people enter into spaces which they imagine will be free and open and equal, such as higher education institutions, to which they have gained access through immense effort and achievement of their own. And then they find in those spaces which ought to be open and free from discrimination, in those very spaces, they experience a rejection and a humiliation on the grounds of judgments that are made about people on the basis of their identity. That is a pernicious and deeply wounding experience, and it's not surprising that that is part of the circumstance that we know has led to tragic deaths in higher education institutions of Dalits, among others, or Adivasis, or other people who find themselves rejected and judged on the basis of their social identity. So a suicide narrative and open dialogical approach doesn't say, well, this is how we will analyze something ex post after the event. It says that we can actually open up and have a conversation about this as part of exploring the suicidality that somebody is caught up in. That's the hope, at any rate. But I completely agree, and it's not just about caste. It's also about the conflicts, the cultural conflicts, the thwarted expectations around, from what I understand, young women with again different kinds of expectations, caught in the frustration of impossible choices, maybe bound up in romantic choices, and how incredibly difficult because of the entrapment that is provided by kin and expectations around those things, or the immense humiliation and the suffering from the thwarted ambitions of marginal farmers who have been relatively successful and made huge investments, hopeful investments in technology and expectations in relation to agricultural inputs, new varieties of cotton or whatever, and who experience losses which are deeply humiliating, not least because of the ambition and the hope and the dreams that those things were sort of signaled. So you're right. There's a wider context. There's always a wider context. But that doesn't mean, and this is really, really important, that doesn't mean that you can predefine or you can pre-interpret or interpret someone else's tragedy or some family's tragedy from the outside. The suicide is fundamentally, at one level, deeply unknowable. And we cannot narrate other people's tragedies for them. And we have to remember that and bring that, respecting something. It doesn't mean you're ignoring the wider context. It's just that we cannot overdetermine and read what's going on as if we know when we don't, and we cannot.
Thank you. There's another question.
Have there been instances where when friends and family are present, there's a blame game being played, and how would we go about navigating it?
Yes, absolutely. In a sense, part of family dynamics is those questions of blame and finding a way of different voices and bringing different voices in. And these can be difficult. You can have a full-blown family row going on in a network meeting. It's not easy. You need the kind of skills to have time out. And this is actually quite helpful when you have this practice of clinicians reflecting. So we could say, well, we're going to stop now. We're going to have a reflection, and your clinician can say, I'm feeling really uncomfortable here because there's a tension here. And so you can create, using the structures of open dialogue techniques, as a way to try to bring the space for different voices to be heard, but not necessarily immediately contradicted or countered. But yeah, this is not. There's no magic to finding a way through, but there are techniques, I think, and processes that in the long run. And that's the other thing about open dialogues. Don't assume that I've learned, just being a practitioner for a very short period of time, just 4 years, that things change. Conversations that are one kind in the early time of a meeting can change over time.
சார் எங்களுடைய சென்டருக்கு ஒரு கிளைண்ட் வந்திருந்தாங்க. அவர் சைக்காட்ரி பேஷண்ட் தான். அவங்களுக்கு சூசைட் அட்டென்ட் பண்ணுறதே மைண்டாகவே இருந்தது. நாங்கள் கவுன்சிலிங் கொடுத்துட்ருக்கும்போது அவங்க ஃபேமிலியிலேருந்து ஒருத்தவங்க அவங்க அப்பா ஏற்கனவே சூசைட் பண்ணியிருக்காங்க, அவங்க தாத்தாவும் இதே மாதிரி சூசைட் பண்ணியிருக்காங்க, இவங்களுக்கு எந்த இது கவுன்சிலிங் பண்ணாலும் நடக்காதுங்கிற மாதிரி அவங்க ஃபேமிலியில் சொல்கிறாங்க. இது சரி பண்ண முடியுமா இந்த மாதிரி இருக்கவங்கள? இந்த ஃபேமிலியில் இந்த ஜெனட்டிக்காக இந்த மாதிரி வருமா?
Well, the answer is open dialogue doesn't fix things in that sort of direct way, but you have a better chance, I think, of addressing the complex situations around suicide if you have a dialogical process. Everything in our mental life is a combination of the biophysiology of our brains and bodies and the things that happen to us in life as part of families and wider society, and we cannot separate those two things one from the other. So the idea that there is a sort of tendency for some suicides to occur within families. My family, tragically, has an awful lot of people who've died by suicide. It doesn't mean that it's a hereditary, inevitable thing that's just going to happen. So I think that's important to state, but also that part of what open dialogue is about changing narratives, about opening up different kinds of possibilities in relationships through re-narrativizing. And one thing that can be re-narrativized is how people talk or don't talk about suicide and suicidality within families, as well as within individuals and other kinds of societies. So we talked about institutions and caste earlier on.
Yes. Sir, thank you, sir, this beautiful session. So my question is, when someone says that they want to end their life, do we neglect or discuss or allow them to continue the conversation?
So do we what?
Do we negotiate and discuss, or we allow to continue the conversation?
Well, my point was that if somebody says they want to end their life, that's an invitation to have the conversation, to open the conversation, to continue the conversation. It makes the conversation quite urgent, but also urgent is as I said, the open-heartedness of that conversation. If that conversation is basically saying, look, you're going to get me in trouble if you do this, I'm seriously worried about me and about my institution, for goodness sake, then that's not open-hearted. And that kind of conversation is probably going to put somebody in greater risk, as the chaplain of the cliff I mentioned said. If you feel that the person is a risk, action is a risk to you, they're more likely to harm themselves than if you're open-hearted about it. But yes, continuing the conversation, I can't see how that would not be the right thing to do.
Thank you, Professor David Mosse, for this amazing lecture. I just want to add on to what my colleague had just mentioned. So if a client who is in distress, as a practitioner, they are coming to me and they're talking about how they want to end life, and they are quite rigid about it, and no matter the kind of conversation flows, that is what the sense that I'm getting as a practitioner, that they just want to end life. So at this point of time, how dialogue, how a narrative practice or an approach can give me a result wherein as a practitioner I need to ensure that the client's safety is maintained, and also at the same time, that's how approaches like the suicidal watch and everything is also into practice, right?
Yeah.
So
okay, so if you've got to the point where somebody is talking about dying by suicide, then obviously you need to find out more. You need to find out everything you can about that suicidality. So you're asking somebody, I want to know more about that. Have you thought about how you might kill yourself? What have you thought about when? Have you thought about where? And if they say, well, I've got this this plan and this, and you say, well, I'm worried about you. I'm worried about that. I think it would be a good idea if we disposed of that medication that you've been accumulating. Can I come with you to your home and let's see if we can remove that means. So you don't say, oh well, bye, we've had a nice conversation about the meaning of suicide, off you go. If there are serious signs of imminent harm, then you have to act. You have to be with the person, you have to do what's necessary, and maybe that what's necessary is that somebody has a period, is hospitalized. It may be. But I have gone to people's homes and collected medication from them. I have gone, taken somebody to a more appropriate space than the one I have, because it's not safe. So I will take somebody to accident and emergency. I will take somebody to a space that is institutionally kind of more protected than I can, because I cannot take on the personal responsibility for somebody who I feel is imminently at risk of harm. So I will talk with them and I will say, well, can we agree that we will go to accident and emergency, we will keep you safe, we will make sure you don't have those things available that could be a source of harm, and I will go with them to that those institutions. So you're not being a sort of superhuman person who is kind of able to protect and do everything. When somebody is seriously harmed, then you have a set of protocols and actions that you need to do. But you're doing so, and you can only do so and really understand what's going on by opening up that conversation. And by being present and genuinely connected, you're making that person safer. That's the point. That's also really important to say. So thank you for raising that issue.
We have one last question and then we shall have lunch.
So, thank you, David. I always love anthropologists, but I think an anthropologist flavored with the open dialogue makes it even better. And so, with you particularly. Now, I have a little sharing that is at the Banyan, and when we learned open dialogue, I felt we've already been sort of practicing this, and to share with many people who questioned, what happens when you do responsibility sharing and all that. So I can say in my practice, both as a in Banyan and my private practice, I find it's much more therapeutic for me, you can say, or the burden or the responsibility or that is much less because it's shared, and there's a system which continues to give care. So all the boxes that we are worried about filling are being done by so many different people. So when there is a constant flow in the ecosystem, it gets done. Like thine will be done. So Lakshmi told me to kiss, keep it short and stupid. So I'm not going to go into a deep French kiss. I'll give an American smooch sort of thing. So my thing is, I've always felt at the Banyan we are already doing this. I used to think it's more transdisciplinary approach. So the question is whether transdisciplinary approach and OD, TD and OD we can say, are they related? Is it a chicken and egg kind of a question? Transdisciplinary approach and open dialogue approach, and so that's one thing. The other thing is another kind of a dream or a hope or whatever you can say, that open dialogue will it have ways in which democracy can be more democratized. So today, if someone has a difference, that is taken as an assault. If somebody has a different opinion, then that's taken as an assault on my opinions, and it becomes into a big tumult. So not only in mental institutions where supremacy and power struggles can be very high, and the last mile, that is the client or the caregiver, they are the receiving end. So who have the least power? So how we raise that? But the same thing in schools, as somebody was saying, suicides and things and all, then IIT and everything, and in other corporations and everywhere. So how can we kind of bring this so that the dialogue itself is more sweeter and more wise? So that's what.
Okay.
Thank you, Anbu. That was a long kiss.
Thank you for the kiss. Great. Yeah, I don't know much about transdisciplinary approaches, but what I would say is I think what's crucial is this team process where you can have a sharing of responsibilities and a kind of mutual support. I think it's much easier to tolerate that uncertainty. This is an open dialogue principle, tolerating uncertainty. I don't think you could do that as an individual. So I think one of the key parts of open dialogue is not just what goes on in the open dialogue sessions with clients, it's what goes on in the team. And if you have open dialogue without those team processes, then I don't think you have open dialogue. You certainly don't have open dialogue in a sustainable way. So I think regardless of whether it's open dialogue or whether it's transdisciplinary, whatnot, it's what matters is the nature of the process and the kind of support that people can give, and the kind of capacity that people have to be present and listen to each other's anxieties and to find a way through. So team building and how to do that, and we're learning quite a bit, and putting my anthropological hat on, because what anthropologists do is they try and understand phenomena by becoming a part of it rather than just going around with a questionnaire survey and so on. So I'm understanding and learning a lot about team processes, being part of that process, and we will have a lot to say about that in due course, because it's not simple, it's not straightforward. I mean, group people are complex, and put them together in groups, they're quadruply or many times more complex. And so there are lots of things we're learning about what works and doesn't work and how teams work. So hopefully that will, but I think basically this question of how we manage risk, how we manage anxiety. I mean, for example, within a team it's clear that people carry the anxiety of uncertainty very differently. So somebody who's a nurse may be deeply anxious about somebody. Somebody who's a psychiatrist or a doctor says, "Oh, what are you worrying about? What are you worrying about? They're all right." That's it. And people have different levels of experience, so they carry their anxiety differently. So how do people with these different kinds of bodily embodied anxiety actually, come to sort of learn from each other? Because we're not all the same in teams. We're very different, and that's something I'm learning as an ethnographer. Stuff about democracy, I can only agree. I mean, with the proviso of what I said earlier, which is that there's a tension between organizations that sort of gravitate towards structure and hierarchy and embedding power, and the kind of anti-structural tendency to try and strive for democracy and so on. And who are the arbiters of whether something is democratic, genuinely democratic, or not democratic? When open dialogue is not representational democracy, it's direct democracy. And I would love to know of examples where this has worked in schools or where this has worked in IT. So I think there's a lot to be gained by thinking open dialogically. I mean, I find myself inadvertently using open dialogue ways of interacting in different ways. Departmental meetings in my university would be totally different. I mean, if people actually listen to each other for a start. So yeah, good points. Thank you.
So I shall propose the vote of thanks. Thank you so much, Professor David, for a wonderful, thought-provoking lecture. And like open dialogue, it's left open. It's kept us open, reflective, unanswered, yet there is a glitter of hope. Very interesting. I love the words that you use, that hierarchies are flattened, tolerating uncertainty. There is a connection between dialogism and polyphony, and that you were able to find links to the Banyan's way of mental health service, of being open-hearted, reflective spaces. Intervision is a wonderful word. And how we sort of also discuss what happens in retrospect in network meetings, and that open dialogue also goes into a depth of cultural change and, on the contrary, enhances resilience. Your case studies of Fareed and Khadija were fantastic, very rich. We were able to connect with that. It reminded me of Abdul Razak Gurna's books on admiring silence. The strain of silence in therapy, in the therapeutic spaces, and how being silent and listening is a very important part of, what is the word of treatment, in treatment meetings and so on. I would also like to thank Madras School of Social Work for hosting a very beautiful therapeutic approach. I mean, this is, I would say, and of course, Vandana and team, for bringing this lens into India. I don't know if there are open dialogue schools or sort of, talks or workshops, but I think it's marvelous and sits well in the Banyan way of working with things. As Dr. Anbal said, sometimes we realize, hey, it looks like we've been doing that, but it's beautifully articulated in this lecture. And of course, SFL, Sundam Fasteners Limited, for hosting these very unusual, important conversations. So thank you so much. And last but not the least, all the students who have patiently waited and asked questions. We're really grateful for you staying back, and we hope that you're able to take some of this. We might have some, probably some programs and workshops and so on, and definitely we'd keep you informed. Thank you so much to everybody, and have a good day. Thank you.
Thank you.
Thank you.